So it's now my pleasure to introduce our next speaker, Dr. Peter Chang-Sing. Peter's been in our community for almost 3 decades and has been a stalwart in developing the subspecialty of cardiac electrophysiology and fostering an excellent cardiac electrophysiology program here in Santa Rosa. Peter attended medical school at Yale, spent some time at Harvard after that in biophysics, did his medical internship at Bellevue Hospital in New York, and then residency in cardiology and cardiac electrophysiology at Cedars-Sinai in Los Angeles. And then shortly after that came to Santa Rosa and has been in practice here. Peter's been involved in many trials for cardiac devices and the treatment of atrial fibrillation. So we welcome him today. Peter?
Thank you, Tom, for that kind introduction. I want to thank Tom and Tucker for asking me to present this 45-minute talk on atrial fibrillation. And as we go through this, it will become more and more apparent that it's been kind of like a journey. So let me start with the first slide. So these are my disclosures. And I just wanted to use a slide to illustrate that atrial fibrillation is a progressive disease, and we tend to see these patients at different stages of the disease, going from paroxysmal to persistent to what we call long-standing persistent, or commonly called chronic atrial fibrillation. And our ability to intervene really depends on which stage of this disease they present in. This is an epidemic that's coming at us. It's the most common arrhythmia, and it brings with it morbidity and mortality that have to be addressed. This is just a listing of the rhythm control agents on the left, the rate control agents, and the anticoagulants that we're all familiar with. It's beyond the scope of this talk to go over the use of anticoagulants. I did this a few years ago, and you're all very familiar with the CHA2DS2-VASc scores that have been kind of laid down for us. Rate control certainly is important in managing the patient. And we have guidelines as to how to use rhythm control agents. These are based on American College of Cardiology, Heart Association, and the Heart Rhythm Society guidelines. As we go from left to right in this very busy slide, what it implies is that the more severe the disease the patient has, the fewer choices you have, so that catheter ablation becomes more and more of a viable choice as we proceed down or proceed further. It's also more of a viable option for our younger patients who don't want to be on medications or anticoagulation. In preparing this talk, I had to whittle down a lot of slides, and after doing that over several days, I realized that this is probably the most important slide that I'm going to show today, because it represents what we have today in terms of the only approaches to cure. All the management that we had before with medications were simply meant to control atrial fibrillation, and the likelihood that any rhythm control agent could maintain sinus rhythm is low, typically on the order of 30 to 40% at 2 years. The strongest medicine is amiodarone, but it has problems in terms of long-term toxicity and just efficacy after a few years. So if you bear with me, the panel on the left represents the first attempt at trying to cure atrial fibrillation. And this comes from the surgical experience. Dr. James Cox at Washington University in St. Louis first presented his series of patients where he did what's called an open maze procedure. This is where patients are placed on bypass, they have sternotomies, and the upper chambers are opened and then cut with a scalpel and resutured together. By doing that, Dr. Cox, who is often introduced as a cognitive surgeon and who politely points out that that's an oxymoron, is able to, with this procedure, disrupt what he considered to be the circuits within the heart that would help atrial fibrillation be maintained. The problem with this procedure, the standalone open Cox-Maze procedure, is that there's a lot of morbidity with it. It's a sternotomy, it involves bypass, and there's risk of bleeding with the use of a scalpel. That said, we do have what's called a concomitant Cox-Maze, which should be used in our patients who are undergoing bypass surgery or valve surgery and have a history of atrial fibrillation. In fact, it would be very improper not to consider that option, because that's your best shot with one procedure or one setting to try and cure that particular patient of atrial fibrillation. In the second panel, we see the attempt by electrophysiologists to mimic the Cox-Maze lesions using catheter ablation. This was back in the early 90s. There were two major centers, Dr. Michel Hassaguer in Bordeaux and Dr. John Swartz at the Armed Forces Hospital in Bethesda, Maryland. And these were exhaustive procedures, 12 to 24 hours, using crude fluoroscopy, using crude catheters. But even in their subset, they were able to effect cures of 40 to 50%, but very high morbidity and mortality. And the FDA actually shut down Dr. Swartz's operation in this country. Our next big breakthrough came in the late 90s, when the same Dr. Michel Hassaguer in Bordeaux published a series of patients in whom he described atrial fibrillation as being initiated by certain foci in the heart, some in the right atrium, but the majority of them from what are called the pulmonary veins. These are the veins that drain blood from the lungs back into the heart. I'm missing a slide, I'm sorry. Oh, here we are, okay. So this is a CT scan image of the left atrium where we're looking at the patient from the back. And what we have on the left are the two left-sided veins draining blood from the left lung, and on the right are two right-sided veins. And in front of that, that little structure that's like an outpouching is the left atrial appendage, or what we call the stroke center of the heart. And what Dr. Hassaguer did, Dr. Hassaguer and his colleagues, was to identify a group of patients who had paroxysmal atrial fibrillation and place catheters into these veins and wait for the atrial fibrillation to occur. Just as he had seen that on these patients with external monitoring, how some electrical activity would initiate a brief episode of atrial fibrillation, he was looking for triggers to initiate atrial fibrillation in these patients. And here we have such a patient who had had chronic atrial fibrillation, who was then cardioverted electrically back into a regular rhythm. And in the middle panel of squiggly lines, usually that's a cue for my cardiac surgical audience to sleep, because they don't like to see squiggly lines. But here we have catheters in the right superior pulmonic vein, and they're recording electrical activity. And we see that this electrical activity starts in this vein, and it sets off an episode of atrial fibrillation in this patient. This is another slide showing catheters in multiple pulmonary veins, and again, this is the instigator. So back in 2000, when we started doing our first catheter ablation at Santa Rosa Memorial, we went after these triggers. We went after the culprit vein. And here what we show is that if we're able to electrically isolate the culprit vein, in this case, the left superior pulmonic vein, so that electrically signals do not go from that vein into the left atrium, we can confine the atrial fibrillation to the vein, but the rest of the atrium is in sinus rhythm. And that's the basis for the pulmonary vein isolation procedures that we have today. So again, we have a summary of different triggers. This is an old way of doing it with fluoroscopy and a catheter in the vein, trying to isolate the vein osteally. This approach was used because when we looked for triggers, it could be a 7-hour procedure. If all we did was isolate the vein, it just depended on how quickly we could isolate each of these veins. We chose the ostial ablation, which has fallen out of favor because there's less work to be done and you can demonstrate isolation, but the problem is that the recurrence rate is higher. Starting in the early 2000s, we began to have mapping systems that actually came to us from an outgrowth of the Israeli Defense Department. There were some very bright engineers there who decided, instead of having a mapping system for national defense, if we had a mapping system within the heart, we could actually generate images and know with our catheters where we had been, where we have to go to, and where we are at any exact point in time. And if we integrate that with the CT scan images and the increased imaging capabilities we began to have in the early 2000s, we can have a very accurate way of safely mapping a patient to affect this isolation. So again, pulmonary vein isolation has become the cornerstone of any catheter ablation procedure, and different people do it differently, one vein at a time, two veins at a time, or the antrum. And again, this is a depiction of the CT image of a particular patient. Each of the red dots represents a lesion that our catheter has delivered in that spot. And what we're trying to do is deliver a contiguous line that isolates the veins so the electrical activity from these veins does not go into the rest of the atrium. And these happen to be what we call linear lesions to anchor the areas that we've isolated together. The problem with the point-by-point isolation of the pulmonary veins is that it takes time, and it's also technically challenging. We're putting catheters from a femoral vein up into the heart, transseptally into the left atrium, and we're moving in a three-dimensional space that's still beating. And so newer technologies came along. In late 2010, the Cryoballoon catheter was approved by the FDA for the treatment of atrial fibrillation. And this is a catheter that's placed percutaneously and transseptally into left atrium. The balloon is inflated, and it's then used to occlude each of the four major pulmonary veins. After it occludes the veins, a refrigerant is pumped into the balloon, and instead of heating the tissue, it freezes the tissue, and I'll show an animation of that. Thank you. So we were rather fortunate at Santa Rosa Memorial. We were the first non-university-based hospital in California to get this system, and the third hospital in California. So this has been a very active part of our program. Here you see a catheter being placed transseptally into the left atrium. The balloon is inflated. You're looking at the osteo of the veins from inside the heart. The balloon is applied against there, and it creates a nice seal. The temperature goes down to minus 60 degrees centigrade, and this is kept in place for anywhere from 2.5 to 3.5 minutes. And after the balloon is deflated, you've created cold damage and a rim of scar tissue that electrically isolates the vein and actually does a better job of, compared to catheter ablation with radiofrequency angiogram. We'll see some evidence for that. So again, we target the vein, we put in our catheters to look for the squiggly lines which represent electrical activity, and we then deliver the energy and isolate the vein individually. And this is a slide showing that isolation with a catheter that's present within the vein, and as you go in the panel from the left to the middle panel, this electrical activity gets delayed and disappears, and this vein is electrically isolated. So before the FDA could give approval for this, they had something called a Stop AF trial, which was in 25 centers in the United States, primarily academic, where they randomized patients who had drug-refractory atrial fibrillation to either drug therapy or the balloon. And the efficacy of this at 1 year was about 70%. And with this, they gave approval to the cryoballoon catheter. And it also established cryoballoon as an accepted energy source to perform catheter ablation. So that's all well and good for paroxysmal atrial fibrillation, where we have patients have episodes of atrial fibrillation that they go into and come out of on their own, and it's usually trigger-based. If we isolate the veins, we usually do a pretty good job. Success over 90%. But in patients who have persistent atrial fibrillation that lasts more than 7 days without an intervention, or who require a drug or a cardioversion or both, the story is not so easy. So not only do we have to get rid of the triggers and isolate the veins, we also have to worry that the substrate, the actual atrial tissue, which because the atrium has been in atrial fibrillation for so long, has now scarred. It's now dilated. Instead of a normal size left atrium, we can have an atrial diameter of 5.5 centimeters. And the ability to restore sinus rhythm becomes much more challenging. So I'm listing here just some of the targets historically that have been used to be used as targets for substrate modification. These are lines that the surgeons use to anchor the mitral valve and the tricuspid valve. There are roof lines. There's something called segmentation of the posterior left atrium, which is very commonly used for persistent atrial fibrillation. We can isolate the superior vena cava, we can isolate the left atrial appendage, and then I'd like to spend just maybe 5 minutes talking about some of the other things that we do. More squiggly lines. So this is called a chronic fractionated atrial electrogram. And independently from isolating the veins, back in the late 90s, there were electrophysiologists who were targeting electrical activity within the left atrium and ablating these sites and showing that in their series, they were able to cure atrial fibrillation in certain patients. And this is just a three-dimensional representation of sites within the heart that show these cafes, and they would then terminate with an ablation. This is a best example. But then for persistent atrial fibrillation, they decided, well, let's target everything that shows a cafe. And this is a 3D rendition where the red points show ablation sites where the operator thinks they're cafes. And it's a lot of lesion sets. There's something called a ganglionic plexus. These are ganglionic cells that have vagal, parasympathetic, and sympathetic innervation and can cause the patient to go into atrial fibrillation. They're well identified in the surgical literature. They tend to be in the epicardial fat pads at the base of the pulmonary veins. And it became fashionable for a while to try and ablate them. And these, again, show the lesion sets to ablate the ganglionic plexi. And this was very hot topic for research back in the mid-2000s. But it hasn't really gained a lot of traction because it's very hard to ablate a ganglionic plexus, which is an epicardial structure, using a catheter from the inside of the heart. And then this is the what's called the firm ablation, focal impulse and rotor modulation. This is the basis for the ads that you're seeing from Stanford for the novel way of ablating atrial fibrillation. And here, what is going on is that two basket catheters are placed in the right atrium and the left atrium, and electrical recordings are obtained. A lot of processing is then performed, and then they attempt to show that there's actually a rotor of activity that's fixed within one location in the heart. They then ablate that location, and the goal is to terminate atrial fibrillation. This was developed at UC San Diego, and the investigators now moved to Stanford. It may show great promise in the years to come. The problem is that a lot of other academic centers have tried this approach, and for them it doesn't work, so they've kind of given up on this. The other problem with this is that the number of patients who've been treated with this therapy is about 1% of those who've been treated with the cryoballoon. And then finally, even at Stanford, when they do these, they always do the cryoballoon. So it's very hard to distinguish how much better this is than the cryoballoon. This is a vest that contains a lot of electrodes that can record in real time the electrical activity with a patient. And coupled with a CT scan, one is able to generate an actual image of a patient, actual patient's left atrium, showing the electrical activity during atrial fibrillation in that patient. Not surprisingly, this was pursued by Dr. Michel Hasseguer from Bordeaux, the same gentleman who showed us that the pulmonary veins had electrical activity. And in Dr. Bordeaux's data set, and this is still work in progress, what he has shown is that there are no fixed rotors, that there are spiral waves that migrate, and it depends on whether or not you're able to disrupt that wave with anchors. And this is in sharp contrast to the rotor story that I showed you earlier. So what causes patients to have persistent atrial fibrillation? This is a little schematic, a little cartoon showing the pulmonary veins from Dr. Hasseguer, late 90s. Dr. Chen Huang from C.C.D.S showed that the ligament Marshall was actively involved in many patients. The vagal ganglia, the ganglionic plexi. Then we've had this theory of dominant spiral waves dating back to 50 years ago. If you can disrupt circuits in this area of the heart, you may be able to cure atrial fibrillation. So when we approach patients who have persistent atrial fibrillation, we start with the pulmonary veins, we isolate the veins, then we do stepwise ablations where we defragment the heart, and then finally we do linear ablations. I say we, but we have never taken this approach. We've concentrated over the years mainly on PV isolation and ablation of something called the right atrial isthmus. These procedures take a long time. You're looking at a 6 to 10 hour procedure with very variable success. Oh, and some of our colleagues have issues with this. Sorry, late talk. I felt I had to put this in there. So what's the success rate of catheter ablation? Well, with paroxysmal, with pulmonary vein isolation, it's over 90%. With persistent, and when I say persistent, I really mean newly persistent. These are patients who can be maintained in sinus rhythm on medications. It's about 70%. But if you have long-standing persistent atrial fibrillation where despite medications, cardioversions, you're still in atrial fibrillation and you've been in it for more than a year, this is about under 40%. And this number I took from Cleveland Clinic, where they have thousands of patients who've had catheter ablation. So it doesn't look as promising. So issues with catheter ablation, especially using radiofrequency point by point, is that you develop incomplete lines. Everything you think you're doing that looks great on the picture isn't really necessarily so or going to be so. And you can actually even do more harm by creating what we call reentrant lines between scar and normal tissue, and then you have incessant atrial flutter. The next thing is that we really don't know how to proceed beyond isolating the veins. Do you do lines? Do you go after cafes? Do you do plexi? Do you do the rotors that people are proposing? Do you do them all and spend 12 hours? You also know that if the patient has been in atrial fibrillation for more than 2 years or have humongous left atria, that your likelihood of success with a catheter approach is going to be very limited. And it also doesn't address the issue of, if you're successful, whether or not these patients should stay on anticoagulation, especially if they have a CHA2DS2-VASc score that's high. So this is probably the second most important slide I'm going to show today. And it's based on work done by Dr. Verma and his co-investigators, where he actually addressed the issue of whether or not we should just do a PV isolation or we should do lines. And he randomized patients to PV isolation alone versus PV with the cafes with the lines. And surprisingly found that after one procedure, the success rate wasn't actually much lower, it's actually maybe better. And after 2 procedures, it was not statistically significant, but it was no worse than just doing PV isolation alone. And so his conclusion was, and this is a just graphical representation of that, was that in patients, even with persistent atrial fibrillation, maybe PV isolation by itself is good enough as long as you do a good one and you take out what's called the antrum around the veins also. And to that end, we have no better tool than the cryoballoon. This is the STOP AF trial, early data, centers with early experience. But this was the old balloon with an area of cooling around the equator. This is the newer balloon that we've had for almost 3 years now with a hemispheric cooling area, so that it's much more effective at completing the line and also getting it cold and scarring. And this is the STOP AF post-approval study that was designed to see what the efficacy with the new balloon would be. It's not randomized, it's just intention to treat. It's only a single arm, all patients get this, and it's meant to follow patients at up to 3 years for long-term efficacy, and enrolled centers that had experienced electrophysiologists. They followed EKGs, Holters, and they took 400 patients, of which 340 actually underwent this, and we have initial data on the first 160 patients. And what we see is that the efficacy is about 15% higher than the first generation balloon. It's about 86%. Freedom from atrial fibrillation at 1 year. The other thing we noticed was with the newer balloon, it took less time, and we had higher success. Less fluoroscopic time, less balloon time, less lab time. So STOP AF from 6 years ago to PS trial, 86% success, less recurrence initially, and phrenic nerve injury. When you freeze the veins on the right side, there's a chance of paralyzing the right phrenic nerve. This is experience dependent. There's a learning curve. This was 3.1% in our experience, and I'm sure in the experience of each of the investigators as they went along, this is dropping. This is under 0.5%. In Germany, it's 6%, because in Germany, they concentrate all the experience in large centers, and every year the trainees come. And in July, it bumps up, and towards the spring, it goes way down. So out of this came something called a value PVI study, which we were fortunate to be asked to participate in, where they compared radiofrequency ablation with cryoballoon isolation in patients who are undergoing atrial fibrillation. This is a study to look at costs and lab time. And they found that cryo was superior to radiofrequency imaging in terms of procedure time, lab time, fluoroscopy time, and length of stay. And it was a better usage of hospital resources, particularly in our environment. So this was published about 2 years ago in Journal of Invasive Cardiology. And this is another study that just got accepted and will be published, where they looked at using an economic value model, since we're all looking at cost today, where they used discrete event simulation, comparing radiofrequency ablation to cryoablation, looking at staffing, overtime, and so on. And the outcome of this was that with cryo, you have more efficient use of your lab time. You have less overtime for the nurses and staff, less overtime days. And this doesn't seem like much, but when you're a busy lab and you're trying to squeeze in a defibrillator and not have burnout in your staff, this is one of the few areas where we've shown actual economic and logistical benefit to using one technology over another. And again, the projection over 4 years of overtime with the cryo versus radiofrequency. So this addresses paroxysmal AFib and persistent AFib. What about long-standing persistent AFib or chronic atrial fibrillation, where with 2 or more procedures, the success rate seems to be capped at 40%. So I'm going to spend maybe 5 minutes talking about a newer approach called the hybrid maze. And this consists of 2 procedures. One is the epicardial video-assisted thoracoscopic surgical maze, which is done by a cardiac surgeon who is skilled at doing this, and is followed 6 weeks later or 8 weeks later by an endocardial catheter ablation by an electrophysiologist. So the first procedure goes from the outside of the heart, the second procedure goes from the inside of the heart. And this is a video showing an animation. And it's based on ports that the cardiac surgeon places. It's done on a beating heart. There's no need for bypass. And through the ports, the surgeon is able to deliver fiber optic scopes and instruments that are designed to create the same maze lesions that Dr. Cox showed us to do 35 years ago. These are the pulmonary veins from the right, and this is a special RF device that goes over, and we're applying energy to create scar tissue and conduction block. We're pacing from the areas that we've isolated to show that the signals don't come outside into the rest of the atrium. We then deliver the line lesions that the surgeons like to do in an open procedure. This is the posterior left atrial box lesion. Now we're going from the left. And from the left, we do the same thing to the left-sided veins. We test for block, what the surgeon does. We complete the line for the posterior left atrium, the segmentation that we talk about. The reason this is so much more effective is that the surgeon will pound this area, 10 applications. When we do it with a catheter, we're doing it point by point, and we're hoping that we can do the isolation, but in effect, we rarely do. This is the left atrial appendage, the stroke center of the heart, and this is a titanium clip that is placed right to the neck of this. This is the atrium, this is the appendage, and it essentially seals off the left atrial appendage and excludes it from the circulation. Now, there are Watchman devices and lariat devices that are meant to do this. But in my opinion, this does it better. Now, this is the second stage. This is where the electrophysiologist comes in with a catheter, and this is the right atrium and the inferior vena cava. Catheter creates lesions here to create what we call right atrial cavo-tricuspid block. We go transeptally into the left atrium, and we test that this isolation that had been performed 6 weeks earlier is still holding. If it does not, we touch it up. So here he's pacing the left atrial posterior box, and there's leakage. So we go in with an ablating catheter, and we seal it off. And by doing that, we've completed what we intend to do for this patient. And some more cartoons showing the lesion sets. It's a bigger picture of that. We're looking at the back of the heart with the left-sided veins and the right-sided veins being isolated and the posterior box being isolated. It's just another view of that. So this is a three-dimensional, what we call voltage map, showing electrical activity within the left atrium, looking at the front of the heart. These red areas represent the veins, and red represents scar. Purple represents viable tissue. And we see that the veins have been isolated. There's no electrical activity in them. And this is looking at the back of the heart. The back of the heart is all scarred, as we intend to do for these patients with persistent atrial fibrillation. Remember I showed you the mechanisms in cartoon fashion, all in this posterior area? If we go back, it's all gone. It doesn't matter what the mechanism is for that particular patient. We've excluded it by doing this hybrid maze approach. So we presented our data at the Heart Rhythm Society last year. We had 2 abstracts, and this one was meant to show that we should do the procedure 6 weeks out instead of on the same day as it had initially been done, and we showed better success by doing that way. These are patients who mean age in the late 60s, CHA2DS2-VASc score high 2s. Most of those were persistent. Some of them had Horner, as you would expect, the type of patient that you would see. Why do we do paroxysmals, even though this procedure is meant for persistence? It's because those paroxysmal patients had either had TIAs or strokes. And in curing their AFib, we also wanted to give them exclusion of the left atrial appendage where the clot might be coming from. So we went straight to a hybrid maze procedure for those patients. And so far we've done over 180 patients. It's actually up to 195 as of yesterday. We have greater than 80% freedom from atrial fibrillation without the use of rhythm control agents in these patients who had had long-standing persistent AFib, and more than 90% if they're on one medication. We have about 10% of patients who still need to be on the medicine. These same patients, though, could not be controlled on any medicine despite cardioversion, et cetera, before we embarked on this. And we're also part of the something called the DEEP pivotal trial, which is a national trial to look at the efficacy and safety of this approach in a more controlled patient. And one of the, interestingly, going back to Dr. Dunlap's talk about risk factors, one of the exclusions is a BMI of more than 40. And it'll be surprising to see how many patients we had to exclude. We're one of the top enrolling centers on the West Coast, but there are so many more patients we could have taken care of if there were not that BMI exclusion. So current strategies for ablation of atrial fibrillation, if it's paroxysmal or newly persistent, then catheter ablation with just PV antral isolation, hopefully using the cryoballoon will be adequate. But if they have long-standing persistent atrial fibrillation, then I think the hybrid maze is where it's going to be. And it brings me back to the first slide I said was the most important slide, and that is that if Dr. Jimmy Cox hadn't had the vision to try and do this with the open surgical maze procedure, we wouldn't have had anything to follow. And if Dr. Hassaguer hadn't had the persistence to look for electrical activity in the pulmonary veins, I mean, it used to be mystical, atrial fibrillation, when I was in medical school, but for them to actually identify it came from the veins, and now everything we do is just built upon that. So again, that I thought was the most important slide. So we were able to do it better, but without their vision, none of this would have been possible. So beyond risk factors such as hypertension, we know that epicardial fat is closely correlated with the incidence of atrial fibrillation. Body mass index is one of the most important predictors of atrial fibrillation. The heavier you get, the more likely you will have AFib. It does it by a variety of mechanisms. The fat infiltrates the muscle tissue of the heart and creates what we call anisotropic conduction, meaning the ability to have re-entry in little circuits. It causes scar tissue, which again creates more circuits. It secretes pro-inflammatory factors, and then there are also ganglionic plexi within the fat that contribute to this. And certainly we feel that weight reduction may reduce atrial fibrillation burden. I don't have any tips, so. But I do know that if you do these things, great things can happen. So, sorry. Thank you very much.
Chang-Sing, thank you for all these years of service on our patients. Wonderful job. The application of cryotherapy, you mentioned 2.5 minutes to 3.5 minutes. What influence had this on your study and the outcome of pulmonary vein isolation and ablation?
So in the previous study, the first study is STOP AF, the applications were typically 4 minutes, and the isolation, as you saw, in terms of long-term outcome was not as good, 70% success. With the newer balloon, we have had application times of only 120 seconds. What that is translated into is reduced procedure time. On average, an AFib ablation takes about 2 hours to 2 hours and 15 minutes. And maybe 3 years ago, that would have been 3 hours. Our morning patients go home the same day.
So, Dr. Chang-Sing, my 74-year-old sister just developed AFib a few weeks ago and has called me from Florida, and she got a cardioversion. We're yet to see whether it holds or not. But what can you tell me that I can tell her about the side effects of ablation? And this is a relatively new technology, but I'm sure that animal technology, animal use has gone on longer. How long does this last?
How long does the success of the catheter ablation last?
Yeah.
Yeah. So, of course, as with any number that I can give you, it's based on how good the data is. So the Heart Rhythm Society looked at catheter ablation for paroxysmal atrial fibrillation, and in their registry, if you're successful with a catheter ablation procedure, the recurrence rate is about 1% a year at up to 5 years. Now, that's a limited study, and certainly from when that study was launched to now, our technology keeps changing. So I showed you how the Cryoballoon second generation is better than the first generation. I showed you how the Cryoballoon first generation is better than RF, as is the second generation. What I've not showed you because of time is that the catheters that we have been using since last summer all have force sensing, so that we feel that we should be able to deliver better lesions, more transmural lesions. So there's a trial called the Fire and Ice study looking at head-on RF versus Cryoballoon, and we'll have that data later this year. But whatever data we have, it's a moving target. Now, for your sister, though, I would think that the more immediate needs would be to establish what the CHA2DS2-VASc score is with just all the risk factors and whether there's need for anticoagulation. There'd also be a need to assess, after she has cardioversion, what her atrial fibrillation burden is. And Dr. Luton pointed out on the first talk today that there are these implantable loop recorders that have the ability to pick up episodes of atrial fibrillation. They're easily implantable. They're like little injections, and they have a battery life of 3 years. And with that, she could determine whether or not her atrial fibrillation will be isolated, since she's just had one cardioversion, paroxysmal, or whether it's trending towards persistent. Now, if the rhythm control agents are well tolerated and work 100% of the time, then certainly she has the luxury of waiting to see what might happen. If, on the other hand, she's exhausted rhythm control agents and the atrial fibrillation is progressing to be a persistent, and if not treated further, long-standing persistent, then her chances of having a successful ablation, or the type of ablation that would be successful, will be very time dependent. And she would probably want to get as much information as she can get and choose whether to just stay with the drug or go for a catheter ablation. Because what I've showed you is that if it's long-standing persistent, catheter ablation is fairly ineffective. But I'm not sure anyone would want to go through a hybrid maze with a surgical procedure, which, by the way, takes about 2 to 3 hours to do and is associated with a 2-day stay.
And the complications, I don't think you went over that.
Complications of the catheter ablation. So there are general procedural complications, hematoma. There's a risk of perforation. We quote that at 1 in 200. there's a risk of stroke peri-procedurally. That's pretty low. It's about 2 in 1,000 now. There's the dreaded complication if we use radiofrequency energy, and again, because of time, I couldn't include everything. There's a dreaded complication of radiofrequency energy where you can develop atrial esophageal fistula. So there's a communication between your atrium, which is sterile, meant to be sterile, and your esophagus, which is laden with all sorts of bacteria that are beneficial, and that communication results in sepsis, strokes, septic strokes, and usually death. The likelihood of that happening based on the registries is 1 in 1,000, but I think there's underreporting, and it's probably more like 2 in 1,000. And that's something that the people who do RF have not been able to kind of shake off as a zero risk complication. With the cryo, there's a risk of phrenic nerve paralysis on the right, which I've indicated to you is really experience dependent. In well-established centers, it's well under 0.5%. And we have enough technology to know that even if there's an acute injury, we should be able to cut our energy and the nerve recovers. It may take weeks, but it will recover.
You almost answered this, Peter, but over here. If you're successful in the cath lab at ablating atrial fib, do you routinely keep these people on anticoagulants for a period of time, or do you do a monitor?
I'm very conservative. So even if we're successful, it depends on the CHAD score. I will not actively, and this is not the opinion I had maybe 5 years ago, but with the CHADS VASC, and I just don't have the courage to do that. So for catheter ablation alone, it depends on the CHADS VASC score. Now patients, though, make their own decision. So you can advise them not to, but say 2-3 years down the line, they feel they have no AFib, and patients who know immediately if they have AFib, they may choose to come off it and go on aspirin. That's their choice, but I don't officially endorse that. For the VATS, the hybrid maze patients, though, that's a different story. We've now excluded the stroke center of the heart with the clipping device. And the surgeons I work with say you don't need to be on anticoagulants. But being a cardiologist and not trying to be counter to them, I still advise that patients stay on the anticoagulants unless there's a reason they can't.
This is another question about the complications during the procedure as opposed to afterwards from the fistula. If there's somebody who died on the table during a procedure, would that have probably been from the stroke, or did there used to be a risk of inducing new arrhythmias then during the procedure?
So the peri-procedural risk, stroke is actually pretty low because our catheters are all irrigated. We have very established protocols. We used to worry about that 15 years ago. We don't worry about it as much anymore. Not trying to jinx myself, but the last stroke was probably 3 years ago, and it involved a little partial visual loss for one of my patients. In terms of mortality, certainly we worry about perforation and tamponade, and I quoted you 1 in 200. We are fortunate to always have cardiac surgical backup. So 9 out of 10 times that this happens, and doesn't happen that often, fortunately, we're able to just do a pericardiocentesis. And we're done with the procedure, and the patient is stable to come back 3 months later. If the pericardiocentesis does not work, that then requires an open repair by a cardiac surgeon. And we counsel all our patients to get informed consent that there's a 1 in 2,000 risk of an open sternotomy and a scar. And if they can't accept that, I'm afraid neither we or anyone else can help them.
So Peter, let me tell you about a patient I saw yesterday and I referred to you. You're going to see her in a couple days or a couple weeks or something. I just want your comments. She's a 39-year-old woman. She's had 3 episodes of atrial fibrillation, each requiring shock. The first was 3 years ago. The second was 3 months ago. The third was 3 days ago. She was placed on diltiazem. She didn't want to take it. After a few days, she had some side effects. And she came to see me
Yeah.
again yesterday. And I don't know if she's a reasonable candidate for ablation or not. She has a normal echo. She has no risk factors. Her C.C.D.S score is 0. And so you're going to be seeing her.
So she's only had 3 episodes. Did the episodes require electrical cardioversion?
Each one.
Each one of them did. And has she tried a pill in a pocket yet?
No.
Yeah. I'm not sure I would want to, if it were me, that I would want to go through catheter ablation with just that much history. I'd probably want to try a pill in a pocket. And I'd also be very sensitive to progression. If it came to the point where pill in pocket didn't work or it was very disruptive of her life. So we've had patients who are like, work for the forest department, they go out 2 hours beyond the road and they can't afford to have an episode of AFib. That's a different situation. But I don't see any urgency in doing anything other than trying some other things first in this patient.
What is pill in pocket?
Pill in a pocket is in patients where we've ruled out structural heart disease or coronary disease, the ability to have the patient take higher doses of the medication such as propafenone or even amiodarone to terminate the episode. So I have patients who have episodes only once or twice a year. They don't want to be on medicines all the time, so we give them 2 medicines. If it's propafenone, then we often give them diltiazem also. So when they have the onset of a spell, we tell them to take the diltiazem, and if 2 hours later they're still in atrial fibrillation, to then take, say, 600 milligrams of propafenone to convert them. If they don't convert after several hours, then they go to the hospital.
Go ahead.
In the same patient scenario, would you recommend that 39-year-old take aspirin all the time, or you don't really?
Dr. Garfield's patient had a C.C.D.S score of 0. So, and the data is also suggesting to us that aspirin, the patients were low risk without aspirin to begin with, is what I'm saying. So it's C.C.D.S score of 0, 1. Aspirin, we feel better giving aspirin. But if we're really worried about stroke, that we need to go with the anticoagulants for 2 or higher. In this patient, I'm not sure, I don't have data on this patient to give you an answer. Certainly if this patient were to have to undergo a cardioversion, even with a C.C.D.S score of 0 and their atrial fibrillation persisted for say 2-3 days, I'd be very timid about doing an electrical cardioversion without having full anticoagulation for a certain period of time, or asking one of my colleagues who does TE and cardioversions to do that instead.
So the trial that compared a radio frequency to the cryoballoon, did that include paroxysmal and persistence, or?
No, that was purely paroxysmal.
Okay.
That's purely paroxysmal.
So the persistence is, or the RFA, is that better?
Well, in the persistence with RFA, as I showed from the Cleveland Clinic data, if it's long-standing persistent, you're looking at less than 40%. I mean, they published a very large series through all the years. And every, if we didn't have data on persistence, half of our AFib meetings wouldn't exist. So at every meeting, people present their approach, doing cafes, doing whatever. And I showed you the data from Dr. Verma, where he did only PV isolation, randomized 1-4-4, and then PV isolation with cafes, PV isolation with lines, and showed that it was no worse to just do PV isolation. In fact, numerically it looked better. And that has been a sea change in our community as to how we handle persistent patients. It's PV isolation fundamentally.
Peter, you had at the end there a good comment on the etiology of atrial fibrillation being contributed to by epicardial fat. Can you speak to other risk factors, hypertensive, heart disease, metabolic things? How big of players are thyroid, metabolic syndrome, those kinds of things as well?
Thyroid, we're all used to in our board exams that you mark it and it's considered, I've never seen a case. But the same risk factors that Dr. Dunlap listed for cardiovascular disease. All of those, you will find studies that show if you modify those, your incidence of atrial fibrillation will go down. Is it enough to not take rhythm control agents? Probably not. To not have an ablation? Probably not. But in many patients, those do contribute. So there's a large study showing use of ACE inhibitors, large trial, and showing that ACE inhibitors reduce the incidence of atrial fibrillation in a large population. So yes, I think, all of those factors count. Paradoxically, we also see in some of our young patients, particularly endurance runners and firefighters, more atrial fibrillation, and they have almost no body fat, no hypertension. And I speculated in those patients, the pulmonary veins get so engorged with blood because of their high cardiac output when they're running up, and all the stress and all the other factors. They're running up with a 60-pound pack into a burning building to save someone. What do you think that does to all the things that might trigger AFib? So that's the other group. Thank you.